Welcome to EM Pulse, bringing research and expert opinion to the bedside.
We're your hosts, Sarah Medeiros
and Julia Magana. Welcome back to EM Pulse.
We are stepping out of our series on medicine on the go to do a quick take on a very real issue that we are dealing with, influenza. And as I just learned from my colleagues on our WhatsApp conversation, there is a new treatment for influenza called baloxavir, brand name Xofluza.
Boy, that's a mouthful, Sarah. And this conversation was hot as our colleagues wanted to know who was using it, when, why, how much does it cost patients, and how does it actually compare to, oh shoot, now I have to say it, oseltamivir, brand name Tamiflu.
So to help us answer these questions, we brought back our friendly ED pharmacist, Dr. Haley Burhans.
Thanks, guys. I'm excited to talk about this. It's very pertinent as I was working yesterday, and I think I verified 80,000 Tamiflus.
That sounds like a very precise number. And about how many I prescribed. No, just kidding. I don't usually do that much. So we are not a CME podcast. So guys, we don't have to use the generic names, though obviously we usually try to use them. In this case, I'm definitely going to mess it up. So today we're going to use brand names just because everybody's familiar with them.
Okay, so Haley, let's do a head-to-head comparison of these two medications.
So these medications kind of broke the scene in the late 90s in terms of antivirals because we used to just use older drugs like amantadine because it blocked the M2 receptor for viral replication. But viruses, as we know from recent pandemics, are way smarter than we are, and they adapt. So Genentech launched oseltamivir, or Tamiflu, late in 1999, which works as a neuraminidase inhibitor to block influenza replication. In 2018, we saw developing resistance in influenza A strains. So Genentech developed baloxavir, Xofluza, which has a novel mechanism by preventing viral replication as a polymerase acidic endonuclease inhibitor. Definitely a mouthful.
Yeah, that for sure is. So wait, it's been around since 2018?
It was approved in 2018. The initial research was in a very controlled patient environment, which I think made it less applicable for clinicians to find the right patient population. And then, of course, we had the COVID-19 pandemic.
Okay, so who should get the Tamiflu and who should get Xofluza?
So Tamiflu has great data in terms of it's been around since 1999. So we know for more high-risk populations, including any pediatric patient, that's any age, patients who are currently pregnant, patients who are hospitalized due to severe or progressive influenza, and severely immunocompromised all receive benefit from Tamiflu. Baloxavir, on the other hand, we know is beneficial for patients who have uncomplicated influenza for ages 5 or older, including those who have high risk factors. And those defined by IDSA include asthma, chronic lung disease, diabetes, heart disease, obesity, or they're age 65 plus.
Haley, what is uncomplicated flu in this definition here?
Uncomplicated flu are patients that do have fever, systemic respiratory symptoms, and potentially other systemic symptoms, but otherwise you as a physician could see them and would feel that they could manage their symptoms at home. They have no indication to be admitted to the hospital at that time.
So not hospitalized.
Correct.
Is basically uncomplicated influenza. Okay, and I just want to step out and say, for years when I've been thinking about who should I give Tamiflu to, I've been using the CDC recommendations and recently, I turned to the American Academy of Pediatric recommendations. They just dropped some at the end of September in 2025. And their recommendations for treatment in the pediatric population is they should be offered as early as possible to the following individuals: any child hospitalized with suspected or confirmed influenza, any child with severe, complicated, or progressive influenza disease, regardless of healthcare status, like inpatient or outpatient, or any child with confirmed or suspected influenza of any severity if they are younger than 5 and belong to another high-risk group, regardless of the inpatient or outpatient status. So I would encourage you to go look at the AAP's recommendations of who they say are the high-risk groups, but I kind of think about it in the category of like bad lungs? Do you have chronic pulmonary disease? Do you have a bad heart? Do you have bad kidneys? Do you have bad liver? Do you have bad blood cells? Like, do you have sickle cell or cancer or something else like that? Do you have a metabolic disorder or neurological disorder, extreme obesity, or, of course, as we all know, immunosuppression? So those are the categories in kids that the American Academy of Pediatrics recommends that group in. Okay, so we know who. Do those same categories apply for Xofluza as well?
Yeah, and I think the reason that they push targeting patients that we know have benefit is to prevent the rapid progression of resistance that we can see amongst the virus by just not giving it to everybody. So it's the same targeted patient population for both Xofluza and Tamiflu.
And it's the same time frame for both of them?
Yes, within 48 hours.
Okay. Now, and maybe there's going to be a difference here in our comparison. Why should they get Tamiflu or Xofluza? Like, what are we trying to prevent with this?
So evidence in the trials that got both these medications approved by the FDA for treatment of uncomplicated influenza showed that it shortened duration of symptoms compared to placebo, roughly 18 hours on average for both of these medications. Fortunately for us, they were both made by the same company, so there's no kind of dicey reason why one would be pitted against the other. So it is kind of nice to interpret. A lot of these studies include placebo versus Tamiflu versus Xofluza. And a lot of times Xofluza and Tamiflu do compare to each other in terms of shortening time to symptom improvement.
Is there a difference between flu A and flu B in terms of when you would give these?
Yeah, so that is a great question. During the Capstone 3 trial, which was used for approval of Xofluza, they actually saw a trend in patients with faster improvement with influenza B who were treated with Xofluza. So the fun way to remember that is influenza B is baloxavir. So both start with B. So if you have a patient, you have a rapid PCR, it is influenza B, it may be worthwhile to investigate if baloxavir is a good option for that patient.
18 hours feels significant maybe when you have body aches and a headache and stuff like that. It's not even 24 hours now.
Yeah, agreed.
And can be complications with these. We're going to get into that. But do they also prevent hospitalization or death or anything else that we typically care about with these treatment modalities?
So there's been a lot of retrospective studies trying to see if it prevents hospitalizations. And unfortunately, at this time, we don't have robust evidence that suggests that's true. However, for adults who are hospitalized with influenza, starting Tamiflu does reduce in-hospital death and shortens hospital duration of stay. For pediatrics admitted with influenza infection, it also shortens their hospital duration of stay. So while it won't prevent them from getting there, it could make their course in the hospital shorter and less complicated.
So one other thing that comes to mind in terms of choosing which med to give is the dosing. Can you talk about that a little bit?
Yeah. So Tamiflu, as people are probably familiar with from recent prescriptions, is dosed twice daily. It is available as a capsule. They also have a suspension for smaller children, and it should be dosed twice daily for 5 days. Baloxavir, interestingly, they decided to go ahead and extend the half-life, so it's 79 hours long. So it's a single dose. It's one tablet. It's also available as a powder that you can make into a suspension at home. And then there are compounded suspensions that pharmacies can draw up doses for younger pediatric patients that are less than 20 kilograms.
That seems like a pretty impressive advantage to Xofluza. Mm-hmm. Is Xofluza easily available? Like, why would you do Tamiflu or why would you do Xofluza if you have an option of one pill versus twice daily for 5 days?
So I think, unfortunately, that's the catch-22 in our United States healthcare system, is while Genentech makes both these drugs, and they certainly made a case for both of them being available, a lot of insurance companies aren't really biting because the data for efficacy is similar between the two. And because Xofluza is newer and novel, they tend to be able to charge more money for it. So a lot of insurance companies are still requiring a prior authorization for patients to be able to get this medication covered by insurance. For example, if you pull up the VA, their prior authorization requires that the patient has to have suspected resistance to Tamiflu, intolerance to the medication, or they can't get it in a timely manner for insurance to cover this medication. But there is one caveat. Genentech did want to make this available to patients, so you can circumvent insurance. They have a copay card where you can just pay $50 out of pocket, which isn't insignificant, but maybe doable for some. And they've partnered up with some pharmacies that do same-day medication delivery to get it delivered to your home.
So they have to just go on to Xofluza.com or something like that? Where do they go?
Yeah, so prescribers or the patients or the pharmacy, which typically we would hope our pharmacists will advocate and help the patients, just apply a coupon code. And it's on Xofluza's website. There's a bin number and a prescription. And so as long as the prescription can get to the pharmacy, they can go ahead and help the patients through that process typically.
Okay, so similar efficacy, maybe Xofluza wins a little bit in dosing, but Tamiflu wins a little bit in terms of insurance coverage and being cheaper. What about side effects for these two?
Yeah, so that is very important to talk about because it's not a fun medication to take. I'm sure if you guys have encountered patients that take Tamiflu, it does make you nauseous. There is an incidence of vomiting and headache. And from post-marketing studies, we think it's about 10 to 15% of patients. And a lot of the GI side effects happen within 2 hours of taking the dose. And if you have to take that twice a day and you already feel pretty miserable, it's not that great. Baloxavir's initial data does suggest that the incidence of GI side effects may be lower. They reported about 2 to 3% in the patients that took the medication during the Capstone 3 trial that got it approved, which is pretty similar to placebo. So whether that's because it's just one dose and patients didn't really report it, or if it's actually lower with the medication, either way, it was perceived to be much lower than Tamiflu.
What about headache?
Headache, I think, is also been more reported with Tamiflu. And again, it was about 10 to 12%. It tended to be higher in adolescents. It wasn't as reported in baloxavir or Xofluza in the initial post-marketing reports.
I think that's one of the things that I always have a conversation with the family about, okay, look, I'm going to give you a medicine. There are these well-known side effects, and we're going to be maybe getting your illness shorter by 18 hours. And risks and benefits and starting it sooner and having access to it makes this a tricky medicine to give and to actually expect patients to take.
It also tastes pretty gross. So trying to get young children to take it is pretty rough.
Yes, the flavoring in the package insert is tutti frutti, which I just read that and I think, no, thank you.
That's funny. Where can people actually get these medications?
So Tamiflu should be available at most pharmacies. It's not over the counter. I know that there have been conversations, particularly for availability because of the timing and onset, but it does require prescription at this time. And if you have a patient that is younger and requiring the suspension, I do recommend that you kind of work with your pharmacy to make sure that it's in stock before that product needs to be dispensed to the patient. But Tamiflu is widely available and you should be able to find it at most chains near you.
All right. So, Haley, what's your takeaway? If you were sick, which medication would you choose, or would you take either of them?
If I were sick, I probably would opt to not take either because they don't sound like a great time in terms of side effects. Baloxavir sounds like a lot of work, unfortunately, to get at this current time. But if I was leaving in vacation in a couple of days, I might find a reason to potentially opt to take one of these medications to shorten my duration of symptoms. But to your guys' point, I think a lot of these conversations, similar to what we were experiencing during the pandemic, are risk to benefit with family. If you have a multi-generational household, if you do have a kid that has asthma exacerbations every season, is it a conversation where we say, look, we know that this might happen and let's have a plan for it? And that's where these medications could improve quality of life, improve parents who are taking care of a lot of kids in their house and just prevent it from spreading if possible. So for me personally, it's probably a no, but there are certainly situations as clinicians where I would advocate for a patient to get it.
Sarah, how do you approach these medicines?
Yeah, I mean, pretty much the same way. I have these conversations with patients a lot, especially on our Express Care telehealth. We have so many patients with flu symptoms right now. And for most people, honestly, by the time they're asking for it, they're out of that 48-hour window. And so I don't think it's going to be super useful for them. But if they are within that window, or they do have, any of these risk factors we talked about, or sometimes extenuating circumstances, about to travel, about to get married, these things, sure, let's try it. So I really think it's kind of a patient-centered care opportunity where you can have that conversation and let the patient decide what's best for them.
Yeah, I have a very similar approach. I follow the AAP recommendations, and those are most of the people that I'm going to be encouraging to take or at least having a more serious conversation with. outside of that high-risk group, because that's for any time, outside of that high-risk group, I focus on, okay, who's within that first 48 hours of symptoms, and then having that conversation with them. I have to say, on a personal level, my son was having symptoms that sounded like the flu, and he was going into finals week. And so on Saturday, I drove to the grocery store to get a rapid swab because I was like, okay, we are taking something. 18 hours matters for you right now.
Totally.
And so there are definitely situations where I would consider it very strongly for my own family and for my own circumstances. But it's a hot topic for sure among emergency medicine physicians because this is not just one easy answer. And there are so many downsides, so many side effects that this is not just just give it medicine.
Haley, what about using these medications for prophylaxis for close contacts with people with flu?
That's a great question. And actually, recent studies came out at the end of 2022 looking at Xofluza for prophylaxis. We know that Tamiflu has decent evidence that if you've been in contact with someone, there's high concerns it is effective for prophylaxis, but so is Xofluza. So I think potentially in the future, that may be an easier route to go down for prophylaxis instead of someone having to take an extended duration of Tamiflu and experiencing those side effects, having a single dose available for them to take and not having to worry about taking anything else to prevent prevention may kind of be a window that Xofluza could outbeat Tamiflu in the future. But unfortunately, again, it's going to be a narrow population because we could breed resistance with that strategy if it's not used carefully.
I find prophylaxis really challenging in the emergency department because I'm often like, okay, do you have anybody in your life who has? And I go over all the risk factor stuff. And then I'm like, okay, they need to go see a doctor ASAP and wear a mask and, don't be around them and wash your hands, all those good things. But getting in with our system is so challenging that them connecting with a doctor to get that is often a hurdle that is too high.
Plug for Express Care if you're in California.
The opinions expressed on this podcast are those of the hosts or guests and do not necessarily reflect the views of UC Davis Department of Emergency Medicine, UC Davis Health, or their parent organizations.